So Matt's going to do talking about nutrition and refeeding for us.
I'm Matt. I'm an SC6 in anaesthesia and ICM, and I volunteered to do talking about nutrition in critical care, and because I thought I had a decent presentation on it previously, so it wouldn't take me much time, but then I realised it was all out of date because things change. So I am going to go through a bit about the importance of nutrition, what our basic requirements are, some evidence and guidance on feeding orally versus parenteral nutrition, a bit about refeeding syndrome, and a bit about gastric ulcer prophylaxis, and probably some other bits thrown in there that I forgot to put in the objectives page. So why do we have nutritional needs in critical care? Well, critical patients have complex, they have a complex interplay between their energy in versus energy out, and although the patient's lying there not doing anything, they do have quite a high energy requirement that's both due to cardiac output, wound healing, surgical stress, and this often leads to extensive catabolism and a massive energy debt. This can also lead to hyperglycemia as the body tries to increase its glucose to be able to feed itself, that you lose lean body mass over time quite rapidly. Some studies say up to 30% of lean body mass at even a few weeks. Changes in serum trace elements, which there's been some attempts to try and manipulate. Fluid retention due to decreased protein synthesis and protein loss, as I said, due to reduced synthesis of visceral proteins like albumin. So what are the consequences of this catabolic effect is that provided with not giving enough nutrition can lead to impaired wound healing in those patients who've had large operations, laparotomies, Ivor Lewis's. We've all seen an Ivor Lewis that's not had enough feeding, that's day 5 or 6, where the anastomosis is just breaking down and they've got albumins of 15 and their wounds start to fall apart. That there is impaired immune response, impaired coagulation due to the liver not being able to synthesize its coagulation factors. The gut goes to sleep, you get ileus, abdominal distension, vomiting, diarrhea, muscle wasting, and this is not only just peripheral muscle wasting and peripheral weakness that impairs rehab potential, but also respiratory muscle function and the ability to be able to get off the ventilator. So what are our overall goals with patients on critical care? So we're trying to achieve optimal nutrition support, i.e. give them the amount they need and minimise any further malnutrition, i.e. to replace any losses prior to coming to us, but also to stop them from losing anything whilst they're on the intensive care unit. And also to reduce the effects of the kind of multifactorial condition that is ICU acquired critical care acquired weakness, which is a combination of many different things that we're still trying to understand, but it probably plays a part of catabolic hormones, mismatch between energy and protein intake and requirements, and the fact that we're keeping them still, paralysed in some cases, and just lying flat. We try to reduce infectious complications due to allowing the patient's own immune system to work, and we're overall just trying to improve patient outcome. So what can all this lead to if we don't get it right? So nutrition disorders can often be classified as malnutrition or undernutrition, so we're just not giving the right amount over a prolonged period of time, and certainly in the elderly in certain conditions like prolonged liver disease or alcoholism can lead to sarcopenia and frailty and just a general lack of muscle mass. Nutrition disorders is also obesity and overweight, which are increasingly part of our patient population. And then we can get the more subtle things like micronutrient abnormalities, vitamin deficiencies, although we're not seeing beriberi and things like that on a day-to-day basis, they do still occur. And then the one that we all kind of get our necks in a twist about, for good reason, is refeeding syndrome, which I'll talk about a bit later. So how does critical illness have its effect on and how does our energy intake and output change over time? So in our very early phase, we get a very high catabolic phase where there is a very high energy expenditure. Your cardiac output's increased or attempted to be increased. You've got surgical stress, infection, that's all trying to drive and need increasing amounts of energy. As this transitions, there's kind of a late acute phase where there is a slightly more efficient use of energy, and then this transitions to the more rehabilitation or chronic phase later, which is there's a gradual switch from this catabolic phase to the anabolic phase. But this anabolic phase is often in the wrong locations. The body will naturally try and preserve its central organs, the brain, at the expense of catabolizing peripheral muscles to be able to maintain the brain. And our overall goal is to try and minimize those early losses in terms of energy and to facilitate rehabilitation later. So, as I said, any insult increases your metabolism and leads to a net loss of lean body mass, and we try and meet those losses and reduce them as much as possible. And we're not just providing fuel, is that we're trying to attenuate any metabolic response to stress. Some would argue, I mean, there's lots of trials regarding giving various nutritional supplements to avoid oxidative cellular injury, but that may be a method of action, and that we're trying to favourably modulate immune responses, though I don't think there's many trials that have specifically shown benefit in these cases, but it's something we can aim to. So we decided we need to give someone nutrition. What actually do we need on a day-to-day basis? And there is the kind of textbook answer that you need to know mils per kilo of water, millimoles per kilo of sodium, potassium, calcium, and other things. But also how much energy do we need and how do we estimate it? So there are a rough ballpark figure for in terms of energy is 25 calories per kilogram per day. That should be roughly divided into the majority of those calories due to carbohydrates, rest due to fats and proteins. The proteins are particularly important because the provision of those is how we prevent lean body mass and how we support the synthesis of vital proteins, albumin, and other things. So in calories, so ideally, well, we should be meeting our energy expenditure, and how we determine that. So in mechanically ventilated patients, you can use indirect calorimetry, but I have never seen it in all the units I've worked in. I've never seen indirect calorimetry actually being used, but so most times we use predictive equations to kind of work out based on BMI, body weight, nutritional status, and roughly how many kilos. There are various different algorithms. There's a Penn State algorithm, and different units, depending on which dietitian, use different values to determine how many calories they're going to provide. So glucose is the main carbohydrate within parenteral nutrition, and you can, depending on where you supply yours from, you can get 40, 50%, 40, 50 or 70%. And then I'll go back to talking about this European Society of Provision of Enteral Nutrition recommends that we should be giving a certain amount of carbohydrate in balance to other energy sources. Protein. So we don't quite know how much. The guidance, which I'll talk about later, recommends about on average 1.3 grams per kilo per day. This protein must also have all essential amino acids that we can't synthesize, such as the ones displayed, which you can learn from an exam if you want, but I'm not going to go through them now. But also in critical illness, we often have these kind of increased demand, but without normal dietary input may not necessarily be able to meet, especially when you're critically unwell. And those are sometimes described as conditional amino acids, is that we can, in day-to-day life, we can supply enough of it, make enough of these ourselves, but in critical illness we may need more of these, but we don't quite know whether we need to replace them more than we normally do. So protein requirements. So I got this from the British Dietetic Association. So in general, somewhere between 1.2 to 1.3 grams per kilo of this is adjusted body weight. Another one of those general fudge factors about how you calculate adjusted body weight depending on what algorithm you use. So roughly, so if you just say between those ranges is probably about right. And of course, in the general ICU population, that's probably taken into account. But in trauma and burns, there's often increased protein losses, especially in burns, due to the lack of the skin continuity and leaking of these proteins out of the body. They need to be supplied more. And on those placements on renal replacement therapy, I haven't quite explored exactly why they need more, but I presume it's due to increased breakdown of proteins due to being on an extracorporeal circuit. And then obese patients, which we'll talk a bit about later, there's different algorithms to kind of predict protein intake, and it's often an adjusted factor on an adjusted body weight, because patients who are obese often have increased lean body mass, but less so than if they're predicted. It's a minefield, which I'll talk a bit about later. So the bit that makes TPN white is all the lipids. It's a very high calorific content, and they're fundamental for nutritional support. They're essential for cell membrane synthesis and all the fat soluble vitamins, including vitamin K, so coagulation as well. We tend to deliver lipids for nutritional support as triglycerides. They can be as medium, long, or very long chain fatty acids. The use of omega-3, high omega-3 content TPN is a bit contentious. Some evidence suggests you would think it was good because it's omega-3 and that's always good, but some evidence that it might be harmful, certainly in the acute phase as well. And there is some concern that soybean oil rich versus alternatives may worsen inflammation and the response to surgical stress in the acute phase as well. So different TPN brands can have different sources of all of their lipids. And then the TPN, the vital amines and the micronutrients that go in. These are in, I don't know whether all places have something similar, that the TPN bag comes as a lipid bit of the bag and then a micronutrient section that you break apart and mix together. These are less stable over time, and that's why they need to be kept separate. And these are all the things that we try that may or may not modulate the immune system, the inflammatory response. They're often antioxidants, and despite all the trials suggesting looking into vitamin C and things, we often think that they're not necessarily harmful in the small doses that we're giving in TPN. We don't have all of the trace elements in there, and these often need to be prescribed separately or added in pharmacy aseptic conditions, and these often in bespoke TPN bags. But we often miss half of these micronutrients and trace elements in some of our ICU population. And we often prescribe some of them like thiamine. We all give either Pabrinex or thiamine B12 in addition to our TPN. But other things that we may not think about, copper, selenium. Selenium's had a few trials going on to see whether it can do things, again, with mixed results. And then all the other weird and wonderful things. I don't think I've ever prescribed anyone vanadium supplementation, but I'm sure someone will come with a trial of that in the future. So with all this kind of information, and we've got about how much we're supposed to give to everyone, it's like, what evidence is there actually out there about how much and when to give it? there's a bit of a contention between the American Society and the European Society, and over the years, and about when to give and how much to give of nutrition, and how to give it. And I was just looking at, there was a 2020 review of looking at the evidence of all of them, and basically said that most of it is all just based on expert opinion, with only about 20 to 30% on average being supported by good RCT information. So we're still relying on expert opinion, which is, as well, not good in a evidence-based medicine. Other trials that have occurred over the years, so to show that we're covering different things, so that the EICU trial, so there was no difference in length of stay, organ support infection, depending on whether you get early or late. The target trial looked between 1.1 to 1.5 kcal feeds, and there was no difference in outcomes. The ferry trial worked out how much amino acids. There's no statistical significance. So people are trying to do all these trials and still not coming up with much decent statistical significance in all these different regimes. So the trials are still ongoing. So how should we, so another trials that have come up is developing of these kind of scoring systems. So a trial looking at to try and validate, or trying to work out who is at risk of malnutrition in the intensive care. So a composite score is the Nutric score. So this was developed part of the Nutric trial to try and find those patients who are most at risk of malnutrition and see if they need feeding early. It used a combination of Apache and SOFA scores, but also required you to send off an interleukin 6, which of course no one did. So you all used a modified score. And the aim was that to try and guide who got early versus later nutrition. So considering there's all this contention, who do we follow? So we in the UK often are general provision of intensive care standards guided by the Intensive Care Society. They recommend the use of this the ESPEN, the European guidance. And those standards, they're a bit dry, so I'm going to kind of whiz through them essentially, but they essentially say that we should assess each patient individually on admission, assess their prior nutritional status, any ongoing recent changes in food intake, absorption, have they got difficulty in swallows, and how about they're going to change over time. That we're recommended to try and commence nutritional support, and this can potentially include parental nutrition if enteral nutrition is not possible, and their guidance is that we should start this within 48 hours if we're not expecting them to be able to get a full oral diet back within 3 days, which is quite common in our intensive care population. How much we give should be set and compared daily, compared to actual intake, mainly so that we're actually guiding our nutritional intake. So, for example, we may say that this patient needs to eat this number of meals a day, but if they're not eating anything, we should top their feed up, and that we should correct deficits. And that we don't necessarily need to be giving full energy targets within the first day, especially if patients are critically unwell, and that giving a massive calorie load during the middle of a period of cardiovascular instability may potentially be harmful, and that we might just give some nutrition. But these are all caveats. As you see, the guidance is may be safe and appears harmful. So even in the national guidance, there's still contention about how much and when to give nutrition. So we give drugs that are often in glucose, or we have lipid containing goods, so propofol, and actually we need to take into account of those calories as well. So propofol, I think, has at least I think it's about 4 calories per 10 mils or something like that. So it needs to be, when you're on 20 mils an hour or 40 mils an hour propofol, you need to take those into account. And patients who are on lots of glucose containing infusions need to be taken into account as well. And those with a BMI of greater than 30, which is a not insignificant number of our patients, we should try and adjust those based on international guidelines. Which ones you pick, I don't know, and it seems to vary depending on which units you're in. And that we should try to take into account when patients miss out on time periods of eating or enteral nutrition to allow us to catch up, and so patients are not always missing out on lots of feed due to interventions, trips to scans and things like that. We should be access to nasal bridles to be able to stop NG tubes coming out. It seems to be varied depending on which units you go to, so some intensive care units use bridles more often than not, and that there should be guidance on how to use them safely because there are risks associated with them. And that rehab of critically ill patients, we should aim to get nutritional targets to support them, and that we should monitor people's bowel habits, which we do. And we should try and avoid drugs that cause constipation, and that we should treat fecal impaction when needed and use laxatives and manage ILIS as well. And then the extreme kind of where GPICS gets this from is the nutrition recommendations in 2019 from ESPN. Again, I'm going to flick through them because there is these kind of all the things we've talked about in the GPICS standards. But the bit I picked out was the standards, the kind of what patients is that early enteral nutrition, i.e. 48 hours, can be safely received. These are the patients you think, should I be stressing patients about? So patients on ECMO, traumatic brain injury, stroke, spinal cords, pancreatitis, GI surgery, aortic surgery, these all are generally considered to be safe and encouraged to get nutrition in. The only caveat, generally the one at the bottom, is that whether you've got bowel sounds or absent bowel sounds, as long as there's no evidence of bowel ischemia or obstruction, that enteral nutrition can be commenced. And then we've decided that these patients are going to, or we think these patients are going to get calories, and we need to consider their risks of malnutrition. So their risk of refeeding syndrome, which I'll talk about in a bit, whether they've had recent weight loss, has their nutrition intake completely dived off a cliff because they've got a bowel obstruction, what is their level of disease severity? Are they just in with a small bit of phenol requirement, or are they in multi-organ failure on quad strength NORAD? What other conditions are going on? Have they got inflammatory bowel disease in addition to their hospital-acquired pneumonia? What is their function of their GI tract? Is there any contraindications to enteral nutrition versus parenteral nutrition? And looking at their BMI as well, and there's, as I said, there's less consensus on calorie goals, and that the guidance suggests you should use urinary nitrogen collection, which involves taking a whole 24-hour sample of urine and analysing it for nitrogen loss to be able to balance their protein intake, which I've never seen done. And then we've decided we've assessed the patient's risk. We sort of roughly decided when we're going to give it. How were we going to give the calories? So are we going to give it, are they awake and can eat and drink, which is the most ideal thing. It promotes gut integrity, chewing, allows the patient to continue swallowing and avoids loss of the swallowing reflex. But that we could also give NG or NJ feeding if that's not able. The downside is this does require another bit of plastic to be put in the patient. And the NG and NJ feed is not without its risks of insertion or displacement or feeding down misplaced tubes, although it's an error event and we all do all the e-learning and to make sure it's not in the bronchus. It has happened and I'm sure it will happen again. And then the other method of delivering calories is parenteral nutrition via TPN. So we know they need calories, so we think they're probably going to be okay to give that via the gastric route or the enteral route. What are some possible contraindications to giving feeding via that? So hemodynamic instability, especially those patients who are volume deplete. This tends to be because they've got splanchnic vasoconstriction, so they may not be able to handle, or may theoretically be promoting gut ischemia if you give them high calorie loads. If there's bowel obstruction, clearly pumping loads of feed into an obstructed bowel is not going to be helpful. Severe and protracted ileus, again, some contention that some feeding may be protective against ileus, but if it's severe and for a long period of time, it's often considered a contraindication. If you've got a major upper GI bleed, clearly this is going to be promoting you to vomit as well at the same time, so there's probably not much point putting feed down. Intractable vomiting and diarrhea. So diarrhea alone is not a contraindication unless it's in the context of high gastric residual volumes. And we talked about gut ischemia. High output fistulas, so these are patients who've got enterocutaneous fistulas with large amounts of enteric output, so that are not going to heal if you keep putting enteral nutrition down. And also, if they literally cannot process any of their or absorb any of the enteral nutrition due to the fact they've got short bowels, those patients who've had multiple bowel resections over time, you've got often less than a metre of small bowel remaining. So you've then decided that this patient's probably not got any contraindications to enteral nutrition. What on earth are we going to give them? It depends on what trust you're in, to be perfectly honest. Often each trust has its own basic standard, kind of bog standard feed that gets put up, and then overnight or during the day or the weekend, and then this gets changed depending on a dietitian input. And certainly at the Royal and the Glenfield, I've not worked at the General, so I don't quite know, but they often have, we always have very good access to dietitians who come around and tweak our patients' feed requirements, and then there's different brands have different sub brands and product lines that have different calories per mil, different grams of protein per litre, how those proteins are break down, whether they're in short or long chain amino acids, whether they're bigger proteins, where those proteins are derived from, and then the ultra niche ones of elemental feeds as well. And then you've decided that you're going to pick the bog standard feed that everyone gets, and then we need to decide how we actually, what rate are we going to give the feed. Are we going to give this as a trophic feed, which is often considered gastric protection at 10 mils an hour, which is often considered safe even in hemodynamically unstable patients? Or are we going to build this up slow, or are we going to build it up fast to the patient's maximum recommended amount or maximum calorie intake? And this is often going to be guided on what we think of their risk of refeeding is. So you started the feed, and then we're going to monitor to decide, are we doing the right thing for the patient and giving the feed? So we should monitor daily, and gastric aspirates are measured, I believe in most places, 4 hourly, and that we generally define gastric intolerance of feed as vomiting, abdominal distension. If the patient goes, this is my abdomen's really hurting, if all of their NG stuff going in is all coming out again. Different units have different cut-offs. Some use 400. Historically, a lot of units use 200 mils. But if you're giving 100 mils an hour constantly, that's probably a normal amount in. Whether the patient's getting diarrhea, is this due to the fact that they're not absorbing, or that they're getting gut inflammation as well? Is there less stool and you're developing an ileus or constipation? Or if any abdominal imaging shows that they're getting bowel obstruction, ileus, or any other abnormalities. So if you're getting increased gastric volumes, what can we do? Well, you can decrease the rate of feed, back it off, and then try and build up more slowly. Or often that we consider giving prokinetics, and we could consider giving those. We know the contraindications of feed intolerance. So if it's just high gastric residual volumes, we can consider giving metoclopramide 10 milligrams IV, supposed to say TDS for 5 days, or erythromycin IV, which are both prokinetics. Metoclopramide certainly has an element of tachyphylaxis or tolerance to, so giving it beyond 5 days is often just risking side effects without any increased benefit. So you've gone all this far to select what feed, how much feed, when to give it, check that they're not being intolerant to it, and then you go and take the patients for a CT scan. They go for an operation. Is that often these calorie intakes are not met, and that how are we going to ensure that they're not missing out on calorie intakes? And that a lot of units are moving towards more tolerating, and certainly in the GPICS guidance, is that we should switch to an overall volume amount rather than just a discrete mils an hour, and that often we can tolerate short periods of higher feeding to be able to catch up to our recommended daily amount, but within a maximum recommended amount for each feed, take into account our gastric residual volumes. And then we've got to consider all of the other drugs that we give down the NG tube, and I'm not going to make you read this, but there is often guidance on when to give drugs with enteral feeds, and some of these are often prohibitive. So I remember trying to give QDS phenytoin to someone once, and you need to stop the enteral feed 2 hours before and 2 hours after. So that's 8 hours a day when you can't have feeding for. So it's quite difficult sometimes to be able to fit these drugs around, and we often have to consider alternate routes for the drugs if available. And then we're going to talk about, we've moved on from drug interactions, so we've had a look back with the thing that everyone worries about when people talking about malnutrition and starting feeds, is that these patients at risk at refeeding? But refeeding itself is just something interesting to talk about. It's often a syndrome that's a life-threatening condition with encompassing micronutrient deficiencies, fluid electrolyte imbalances, and disturbance of organ function and metabolic regulation. And it was mainly originally found in post-liberation Netherlands, after the population had a massively calorie restricted diet for a long period of time, and then after liberation in the Second World War they were provided with very high calorie intake, and there was a sudden increase in the mortality of the population, and that's likely as a result of refeeding syndrome, and it can lead to cardiac failure, pulmonary edema, dysrhythmias, death, and general badness. So when you're in a fasting state, your body switches from using all the nice lovely carbohydrates that are available, and you switch to fatty acid metabolism. Your body produces and tries to make fatty acids to preserve the brain. You suppress your insulin secretion because you're not getting any carbohydrates in. You're not getting your minerals and your trace elements, so your intracellular minerals get depleted. But in order to preserve your membrane potentials, your serum concentration often remains the same due to homeostasis. And then you suddenly give a load of calories to someone who's not had anything for a while, and this increases your metabolic rate, increases your glycogen, fat and protein synthesis, and this taxes your already depleted phosphate, magnesium and potassium stores, which can cause rapid serum changes, which causes membrane instability. You form phosphorylated compounds in the liver to try and, as part of your build-up, and this depletes your ATP. You don't get enough energy to tissues, you don't give enough oxygen to tissues due to red cell dysfunction, and this can also contribute to organ failure and dysfunction. And we talked about the intracellular movement of ions due to rising insulin levels can also lead to decreased serum availability of ions and membrane instability, arrhythmias and seizures, and this is more specifically with magnesium and potassium. But depletion of in the phosphorylating the compounds, if you deplete your serum phosphate, you can get respiratory weakness and therefore predisposed to respiratory failure and difficulty getting off ventilators. So who's at risk? So a number of different people. Classically, we all think of those people with anorexia, but we don't tend to have, outside of specialist units, a huge amount of people presenting with primary anorexia nervosa. Alcoholics, so often have a relatively calorie rich diet in terms of pure carbohydrates. Alcohol is a form of a carbohydrate and has a calorie amount associated with it, but tends to be trace elements, vitamins, poor, and these patients are at high risk of refeeding syndrome, and also have ongoing probably liver abnormalities with decreased protein synthesis over a long period of time. Patients with substance misuse and patients undergoing chemotherapy, and this is probably due to the risks of mucosal upset due to chemotherapy causing decreased oral intake, as well as the direct toxic effect of the chemotherapy itself. So how do we take into account these risks? So patients we identify at risk, we often start slow and we get early involvement with dietitians is the main thing, who can guide us in terms of what rate to increase our feeds, what micro and macronutrients to include, and what supplementation with things like Pabrinex, thiamine and B12 we need to consider adding, and also that we need to be checking our phosphate, magnesium and other serum ions on a regular basis. Sometimes if those patients that we think are developing refeeding, that we check them at least twice a day. Other patients that are maybe going unnoticed in terms of maybe malnourished are the patients that at the end of the bed you think, oh, well, they're clearly very nourished because they're obese, but actually this can mask overall nutritional deficiencies in patients who are, so we say, lipid rich, but are not necessarily protein rich. They may have decreased muscle mass, and they may decrease muscle mass more quickly because they the fat has a metabolic requirement that will be taking away energy from the lean body mass as well. And that all our predictive equations for trying looking at these patients, they're often a starting point, but from what a lot of the evidence I've looked at shows that indirect calorimetry is more helpful, but not many units have access to it outside of specialist liver centres and bariatric centres. So these patients are often at risk, and we need to take more care in looking at them. And there's often a lot of subjective biases. You just see them at the end of the bed and think, oh, they can tolerate a bit longer without feed, but actually these patients are ones that we need to take often more care at and looking at. So the other bits I wanted to look at was in terms of the thing we always prescribe is gastric ulcer prophylaxis. So generally we think that if there is generally needed if they're going to be ventilating more than 48 hours, or if the patient's on a long-term PPI due to hiatus hernia or other reasons why they might be on. If the patient's on established feeds, they're not hemodynamically unstable, we could potentially just back off this yet another medication we're giving on ITU and de-escalate, unless the patient, they have risk factors for GI bleeding, i.e. they've got a known ulcer, they've on multiple anticoagulants on treatment dose Clexane or unfractionated heparin, for example. In the olden days, we'd be using ranitidine, but now everyone's on a PPI of one flavour or another, either IV omeprazole, oral lansoprazole, pantoprazole, depending on where you go. And those patients are risk factors for GI bleeding, so coagulopathies, mechanical ventilation for more than 3 hours is a risk factor GI bleeding, which is why we provide PPIs for them. History of GI ulceration. We don't quite know why, but traumatic brain injuries, spinal cord injury and burns are more at risk for GI bleeding. It may be something to do with the brain-gut axis, but we don't quite know yet. And there are other criteria as well, including steroid use. So overall, I've tried to cover why nutrition is important and what we think our nutrition requirements are. But a lot of the other bits about when, how quickly to deliver these nutrition requirements are still quite contentious. And I think the main thing is that we stick to our local guidance. We reevaluate the guidance over time. We get the important input from dietitians, because these are the people who actually sit down and work through exact calorie requirements, nitrogen requirements, protein requirements, nutrient requirements for our patients, that we don't necessarily go into that detail. Refeeding syndrome is bad, and that we should still consider patients who are at risk and consider it all times. I think everyone does pretty well, and that we give gastrointestinal risk gastric ulcer prophylaxis to patients who are at risk, but also de-escalate where we need to. So thank you very much for paying attention and sitting through I've tried to whiz through the dry bits, but I'm sure that it's a bit dry in places. But are there any questions from any of the rooms around UHL that would like to ask any questions at all, which I can't promise to answer, but I will try.
And silence.
And silence. Talking about nutrition whilst you're trying to get nutrition into yourselves during the middle of a lunch break is probably.
I could see some chips. I think it's okay.
Yeah. There's someone of having a perfectly balanced mix of carbohydrates and lipids, because I did see there was a pizza being intaked as well.
Yeah, okay.
Yeah, the thing to remember is just it's one of the attention to detail that we try and do on ITU. That's why feeding is in the flat hub, so to make sure that people are getting this, because it does make a massive difference. And it's enough if they haven't been eating and drinking for a week before they make it to us, because they've been unwell with their whatever the pathology they've come in with, then it's enough to give them Pabrinex and make sure you start supplementing them fairly quickly. It's fairly simple, but it does make, like you say, it does make a huge difference.
And it certainly supports getting people their onward trend as well. So not just when they're in ITU, yeah. Is that we can deliver them through their critical illness, but if they're massively weak, they're not going to be able to rehab quickly. They're going to stay in hospital, and then they're at risk of further deterioration.
Yeah.
I think
the BMI thing's quite controversial, isn't it?
Yeah.
Because it does make a surprise. It seems weird in a way, because it's a bit alien to the rest of medicine, but actually bariatric people, obese people, tend to have better mortality. At least it's a bit of a U-shaped curve. If you as you get really underweight, normal weight and then underweight, your mortality goes up, and it gets a bit better as you get bigger. Eventually, obviously, it will get worse again. But
yeah, I think there's a lot of things about obesity we still don't understand, and the actual metabolic actions and hormonal actions of adipose tissue is still being understood. And what do we do with it? How do we treat it as a condition?
Yep. Okay. Did anybody else have anything they want to add? No.
Anyone at the Glenfield with a recent edition of hepatobiliary, and I'm sure nutrition is hot there.
We have the dietitians keeping an eye on us, so they tend to stop us from doing anything too stupid with our HPP patients.
Yeah.
It's the pancreatitis patients, acute pancreatitis, that are a bit of a nightmare, aren't they? You're trying to get food into them.
One of those recently. We haven't seen much of pancreatitis from the HPB in the last month or two. I don't know why, but we just haven't had much.
Well, hope it continues.
Yes, definitely. Pain in more ways than one.
Indeed, yeah. Okay, cool. Well, thanks, Matt.
Thank you.
My name is Abby. I'm one of the dual ICM and anesthetic trainees, and I'm going to do the journal club for today. So the paper I chose is actually a randomized clinical trial that happened in 1890 years in Germany, and it was published at the end of August at the Journal of Intensive Care Medicine. So the title is beta-D-glucan-guided antifungal therapy in adults with sepsis. This trial was named CANDICEP, and it's a randomized clinical trial. Now, the background for this study is that invasive candida infection has a really high mortality, up to 80%, if no treatment is given within the first 24 hours of septic shock. The current guidelines, at least the European ones, I hope we're still on those, suggest early antifungal treatment in critically ill patients with a high risk of invasive candida infection. But in general, they give only a little advice on the selection of appropriate patients. They're also very cautious to recommend the BDG guidance to trigger antifungal treatment because there are limited data. However, in previous trials, it has been shown that BDG-guided antifungal therapy is safe. It may aid to stop antifungals, and it might select patients that they will benefit from empirical antifungal treatment. So in their study, Germans wanted to investigate if BDG shortens time to antifungal treatment, and therefore it reduces mortality of sepsis in patients that they have high risk of invasive candida infection. Starting a little bit with methods and everything else. So in general, the inclusion criteria for this study were mainly adult patients. They were in severe sepsis or septic shock. The time frame for the enrollment was 12, but then they amended a little bit later during the years in order to increase actually the number of patients that they could recruit. So then they did it up to 24 hours from the diagnosis of severe sepsis or septic shock. And they should be at high risk of invasive candida infection. And their choice of this group of patients were patients that they were on CPN, patients that had abdominal surgery in the last 7 days, patients on antimicrobials for equal or more to 48 hours within the last 7 days, or acute renal failure that it required renal replacement in ICU, or chronic renal failure, so patients that they have like dialysis, etc. So they screened 2,324 patients. Their exclusion criteria, so what they tried to do is to keep into the study patients that they were actually high risk of having an invasive candida infection and would give them the less false positive results. So they took off, like cirrhotic patients, patients on immunoglobulins, patients that they were on immunosuppressions, patients that they were already on antifungal. And also there were other reasons like patients were excluded because they were not on the time window that it was already mentioned, or they were too sick and they had a very poor prognosis. So the exclusion criteria took off 1,770 patients. So actually they were left with 342 patients that underwent randomization 1-to-1. These patients were split into 2 groups, the control group and the BDG group. This is how we're going to call it from now on. So again, some of the patients, like withdrew consent during the study. So at the end, the control group included 167 patients, which were followed up for 28 days, while the BDG group had 172 patients. Regarding the trial treatments, for both of the groups, BDG samples together with blood cultures, they were taken within 1 hour after randomization and 24 hours after enrollment. From thereafter, in the control group, the treating physicians, they were blinded to the BDG report. So they were treated according to the standards of care. And when we say standards of care, we mean they were actually just waiting to have, like positive blood cultures or have some sterile tissue actually positive for Candida. In the BDG group, the clinicians were informed as fast as they could about the result of the BDG. And any patient that had the BDG concentration of more than 80 picograms per ml, it had to be treated with antifungals suitable for an ICI. If only one of the BDG concentrations were more than 80, and then they have a blood culture which was negative for Candida species, then the antifungals, they would just be stopped. But if the patients had two concentrations of BDG above 80, which was their cut-off, even if the blood cultures, like they were negative, they would still continue the antifungals. So the authors then collected, like all the data, and they set the endpoints of the study. So the primary endpoint, it was all-cause mortality by 28 days after the inclusion to the study. They had a lot of secondary endpoints, like the antifungal-free survival within 28 days, Candida colonization, time to antifungal therapy, the cost of antifungal therapy, the duration of organ support until day 28, the mean total SOFA score, ICU and hospital length of stay, ICU and hospital mortality, and any frequency of adverse events. Now, starting a little bit with all the descriptive statistics and everything else in the beginning. So in this table, they just show the characteristics of the patients on baseline. As we can see, on the right side, we have the BDG group. You can see it here. On the right side, we have the control group. So as we can all see, the patients were balanced in terms of age, sex, body mass, comorbidities, different scores like the APATSI, the SAPS, and the SOFA, lactate, procalcitonin levels, septic shogs, days in ICU, days in the hospital. So we'll keep this well balanced. Yeah. Going further into the descriptive statistics. So in terms of which was the most frequent risk factor for invasive Candida, in their population, at least what they studied, they found out that recent abdominal surgery was the most common risk factor. And regarding the focus of the sepsis, abdominal was again the most common one. Now, in the initial bloods and cultures and everything, so 15 patients, they were positive in the blood cultures for Candida. 6 were positive only in PCR for Candida. And the levels of the beta-D-glucan, they were like quite similar actually in both groups. Continuing with the results, they found that on the BDG group, in total, 48.8% of the patients received antifungal therapy, which is like quite different actually to the one to the control group, although I think that we were expecting it a little bit. So 84 patients had antifungals from the BDG group and only 10 in the control group. Coming to the primary now outcome of the study, I'm sorry, I don't know if you can see it very well. I just tried, like to increase the size and everything. The 58 patients died in the BDG group at the end of the 28 days and 51 in the control group. As we can see, the p-value, it's 0.53, so it wasn't statistically significant. In terms of survival, the authors also tried to show, like the results in a Kaplan-Meier curve, and it shows the estimates of the survival rate at different time points. So at 7 days, 14 days, 21 days, and 24 days. And on the graph, the solid line is the BDG group. while the dotted line is the control group. So there was actually no obvious change. So the authors then analyzed the data in order to identify if, okay, they didn't see, for example, any change in the mortality, like in the group of the patients, but is there any specific category of patients that could maybe, like benefit instead of pulling all the patients as one? So they did a subgroup analysis. The way they decided to do the subgroup, if we go here on the left, the subgroups were patients that they had 2 positive BTG results, patients in septic shock, patients that had more than 2 of risk factors for an invasive candida infection, patients that they had a candida culture positive, or a PCR result positive in the serum, and patients that they had a candida colonization index of at least 0.5. Just in a parenthesis here, the candida colonization index enters in the study because it has been shown in previous study that if you have a higher index of colonization, you probably are going to have a higher risk also of invasive candida infections. Yeah. So on the right side of the screen, they did the forest plot analysis for the different subgroups. So as for every forest plot analysis, like the squares that just show, like the relative risk. The vertical line shows the line of no effect. Whatever is on the left, it would say that the BDG group did better. Whatever is on the right of the vertical line, it would show that the control group did better. So all in all, there was no change. So none of this subgroups benefits actually from the BDG approach. In regards to the secondary outcomes of the study, so on the left side, here on the left side, you can see which they are. I'm going to mention them. Then the first column here is the BTG group. This is the control group, the relative risk, and here we go to the p-values. Okay. So let's start for the ones that they're not statistically different. Okay, so in regards to hospital mortality, hospital length of stay, ICU mortality, ICU length of stay, and costs of antifungal therapy, there was no statistically significant difference between the control and the BDG group. Although I just want to say that if we go to the costs, we can see that actually the BDG group costed them 4,451 euros, while the control group, it was only 2,800. So I cannot know if we can convince managers with that, but I'll just throw it out there. Yeah. Regarding the candida colonization index, so there was, in general, it was pretty low. Yeah. And it showed no difference between the 2 groups at the beginning, at day 1, day 7, and day 14. Yeah. Also, there was no difference in the total SOFA score and the organ support that the patients got from ITU in terms of vasopressor-free days, ventilator-free days, and renal replacement-free days. Okay, so no difference. It doesn't matter if you do the BDG or you don't follow a BDG approach. So the only things that they were actually significantly different statistically was the time to antifungal therapy. Okay, so how many days it took for patients to start to antifungals. So we can see that on the BDG group, this was 1.1 days in average, while in the control group, it was 4.4 days. So yeah, definitely you start earlier the treatment when you have the BDG. The other thing which was significantly different again was the antifungal free survival day at day 28. So as we can see here in this row, 52 patients in the BTG group were without antifungals at day 28 versus 87, which is something again I think that we expected a little bit. Yeah. So They analyzed the data also in terms of a Kaplan-Meier, and this is the curve that estimates the rate of the patients that they were not on antifungal therapy according to the BDG group. So again, the solid line, which is the lower one, shows patients that they were on the BDG group, while the dashed line shows the patients that they were in the control. On the y-axis, we have patients not on antifungal therapy. This is a percent actually of the patients. And on the x-axis, we have the time to antifungal therapy. All in all, more patients received antifungals in the BDG group. And we can see that from this dip, like steep going down of the curve, that most of the patients, a high percent of the patients got antifungals really, really quite early and not in many days. So in their conclusions, the authors say that early administration of antifungal therapy guided by serum BDG did not provide an advantage over standard of care as measured by the 20-day mortality among critically ill patients with sepsis. They do not support the BDG guidance for initiation of antifungal therapy in this patient's at least population. However, they are mentioning that their rate of invasive candida infection was very, very low. Yeah. So we are going to see how they discuss that and how could this affect their results. They're also suggesting that a possible benefit of serial BDG measurements in a more selected population at risk needs to be addressed in future studies. Now, how do they discuss actually their results, and what do they take as a result out of that? Is they're saying that in their study, BDG had a very low specificity. And they suggest that open gut surgery results in elevated serum BDG concentrations for up to 5 days. So this could have impacted actually on the BDG measurements, and the lack of specificity likely caused an overuse in antifungals, mainly in the BDG group, and in patients even that they had, like no microbiological proof of an invasive candida infection. Also, the sample size calculation, it was based on a mortality of 49.8%, but it was much, much less in their case. And this could be explained by the fact that they had a higher frequency of Candida albicans infections rather from Crusade, for example, that has a higher mortality. So this could have affected their results. What I found important in their discussion is that in their inclusion criteria, they aimed for patients that they had a high risk of an invasive candida infection, but surprisingly, their population wasn't one of them. So they only had 15 cases of proven candidemia, which is supposed to be a low one. And they speculate that the inclusion criteria did not result at the end in a pre-selection of population with high risk of an invasive candida infection, and BDG may thus not have unfolded its full, diagnostic benefit. All this makes quite sense to me. All in all, the CandiCEP trial has some strengths and of course has some limitations. So regarding its strengths, it's a multi-center randomized control trial. So there were 18 ITU in Germany that they recruited patients from 2016 to 2019. They had a pretty good, actually, randomization, and they had a sufficient separation between the groups regarding the timing and the frequency of antifungal therapy. In regards to the limitations, they are admitting that there were some delays in the measurements and reporting of the results of the BDG because they had to go to a central lab. So this could have delayed treatment. The time window also for the recruitment, as I mentioned earlier, it changed. So in their initial protocol, they wanted to have it at 12 hours, but they didn't have enough numbers. So somewhere, like in half of the study, they just changed it and they increased it to 24 hours. There were some deviations, again, also from the protocol, mainly addressing the duration of antifungal therapy in the BDG group. And finally, the investigated intervention did not allow for blinding, so it could have, like this trial, it could have been affected by performance and selection bias. So that's it. I finished with that. I don't know if any of you saw any, I don't know, like we want to proceed. I actually prepared a couple of, like slides regarding, like the different kinds of candida and the BDG, like advantages and disadvantages of PCR and blood cultures, but I don't know how much time we have and how you feel about it. If you don't feel like it, I can always, like email the presentation and you can, like just have it. What would you like? Would you like? Yeah, I wish. So I guess we have 10 minutes. So I'll just try and be like as quick as I can. Right, so 15 kinds of Candida species. Only 5 are the most common ones in humans. When we talk about invasive Candida, we talk about candidemia and deep-seated infections. Pretty high mortality, as we said earlier, about 47%. And it is really, really closely linked to giving, like antibiotics very, very early, and also source control. This is to remind it to our surgeons. So candidemia can be divided into primary and secondary. So the primary stems most often from the GI tract after translocation of Candida, or through a contamination from or colonization of an intravenous catheter. Yeah. And then we have the secondary candidemia, which results from a non-hematogenous introduction of Candida into sterile sites. And usually it's most common in the abdominal cavity following GI tract disruption. So when we want to choose, like diagnostics tests and what do we expect from them, is that they have to be good enough to identify candidemia in the absence of deep-seated infections, candidemia associated with a deep-seated candidiasis, or deep-seated infections, but with no, like candidemia. So they should be able to separate it because they're separate entities, actually. Yeah. Now, starting with the blood cultures, this is a very, very typical and standard test for the diagnosis. The cultures are sensitive at detecting viable. Yeah, it's viable. It's the only test actually that I can show you viable, because when you're using the beta-D-glucan or when you're using the PCR, you're just seeing pieces of something. You don't see the whole organism, all right? So blood cultures are positive in most patients if samples are collected during active candidemia. However, they are positive only in 40% of patients with candidemia complicated by a deep-seated infection, which persists after a candida has been cleared from the bloodstream. Yeah. Cultures also, when we get them from tissues that we take, yeah, they only are 50% sensitive, and this is likely to small samples, so you don't get enough bacteria in order to, like culture them, and there is a low burden of candida cells. So a very, very big, like disadvantage of the cultures is, of course, the slow turnaround time. Yeah. In terms of the non-culture diagnostics, so we have candida antigens, anti-candida antibodies, and we also have the PCR. Yeah. So the candida antigens, BDG is included in this. It has a low serum concentration, and it shows very rapid clearance from the bloodstream. Yeah. In terms of what it is a cell wall constituent of candida, and also you can find it in a lot of other fungi, which is a disadvantage because you can't differentiate between candida and other fungi, or you can't differentiate between the different species of candida, yeah, which might have a completely different mortality, a completely different profile of an infection. The sensitivity and specificity for invasive candidiasis when we're using the BDG are about 80%. The performance is usually better when we have 2 consecutive positive results rather than having 1. So the major concern of over BDG testing is false positivity. So there are a lot of factors, that they affect the results. So patients that they are taking, for example, hash, so they take albumin, patients that they are on hemodialysis or they take certain antibiotics, they are on enteral nutrition, they have mucositis, or even some gram-positive bacteria, they can give you full positive results. So it doesn't mean that you have candida or you have, like candidemia or something. It's just a false positive. So we always have to link it actually with the clinical picture. So it's a lot, right? I agree. I didn't know that it would be such a, I would, for example, like I knew about the immunoglobulins, like I knew about the albumin and stuff, but not all of this. Yeah. Yeah, it's impressive, isn't it? It's impressive. So yeah, I mean, we have to take into terms the clinical picture, like temperature, like white blood cells, like a lot of other things. So when we're talking about the Candida PCR, so the Candida PCR is usually for the bloods. Yeah, well, the blood cultures, we can do it for the blood, we can do it for tissues, we can do it for everything like that. So it's even worse actually to interpret the data from a PCR, because as we said, like you might have a dead, like fungi there, but it will amplify the DNA. So you are going to have a positive PCR, but it doesn't mean that you have candidemia. Again, the PCRs, it's not something like standardized, like different labs, they have different primers that they're using in order to build up the in-house PCR. So there is a lot of different, like different labs, different things. This can not being capable of also of differentiating between other fungi or other bacteria. However, the only advantage I think of the PCR is that if you choose the primers that they're using to amplify, like the DNA, they can differentiate between the different Candida species. Okay, so that's an advantage. Okay, so that's it. I think I was just, like try to read a little bit more about like the Candida. I just wanted to share, like all these details with you. I'm just going to send the presentation, and yeah, that's it. Thank you.
Thanks, Ellie.
Thank you. I hope it wasn't very boring, but I just wanted to, say.
No, it's not boring. The microbiologist did some teaching on antifungal treatment last week, I think.
Okay.
And they were happy for us to share it. I did, if you look on the chat for the ICM teaching group on Teams, I did put the link on there. So if anybody is interested and wants to see what the microbiologists say about fungal infections on the unit, then you can click on that link and watch their teaching. It is there. All right.
Your study discouraged empirical antifungal treatment, isn't it? That's what you're. Like the article said that actually you use it or you don't use it, it will not affect mortality in the sepsis, in severe sepsis in septic patients. However, they had a very low percent of invasive Candida infection. So actually, if they had chosen a group differently, or if they were an ITU that they have a higher, colonization rate of Candida or have more candidemias, I don't know the profile of our ITU to tell. It could be actually that, like these patients could benefit. Yeah. The way that we do it, I think we put empiric antifungals and
de-escalate them.
Stop.
So that is the thing. We use this, and it's correct. So the study answers a different thing. So what we do here is we start them and we de-escalate. They were trying to find out if BDG will help initiating therapy rather than de-escalating, which is a different thing.
As you mentioned, it escalated quite quickly from the bloodstream.
Yeah.
And
Blood culture is the only viable for it.
Yeah, but it takes like 96 hours, you know, like at least like, so it takes a long time. So they wanted to see if, for example, so first we know that mortality is very, very high if we don't give antifungals in 24 hours. So my first question is, how can I make it safely, effectively, and fast, you know, like to have something in my hands to say that I can start antifungals? So this is why I would like to have the BDG and just check if it is helping me. And then, yeah.
You just said that if we don't treat in the first 24 hours, there's a high mortality rate. However, they didn't have any difference between the two groups. So the second group would have had most of them starting antifungals in day 4.
No, so this was the Cultures Act. No, so in the BDG group, they started the antifungals in 1 day. And this is why when they sent the BDG results, the control, it was about 4 days, they're saying.
Exactly, but there wasn't any significant difference in mortality.
No, there wasn't. But again, it's a very weird group of, how can I say, they are not very sure in the study.
Did they not think that the result is clinically significant? Is it not powered enough to be significant?
So it is powered enough. So the power was enough, but they don't think that the group that they chose at the end, just because they had a low rate of candida infections, probably what they want to say it's not appropriate. But if they were in ITU, that they had a higher risk of candida infections, they probably would have shown more differences between the control.
I don't see how that actually makes any sense.
It makes sense because when you have it makes sense because when you have an ITU, for example, that they have patients that they are indeed at high risk of candida infections, and then you use the BDG or you don't use the BDG, this is where you're going to find major differences in your results. You're not going to.
Are you saying that because the group that they had, they weren't as high risk, as a high risk group, patient group?
Exactly.
Exactly.
Exactly. This is what they're saying. It's not me actually trying to say it.
My takeaway from this trial is they have screened close to 2,600 patients.
So
through 340 patients, that will be approximately 6 patients per ITU per year. The exclusion criteria list is so long.
Yeah.
You essentially exclude every patient who is at a high risk of invasive candida infection. In that highly selected subgroup of patients.
So no, they included patients that they were deemed as high risk of candida infection. And this was, as I said, the inclusion criteria.
The exclusion criteria, immunosuppression was an exclusion criteria in this trial. So that essentially rules out a significant number of patients.
They were trying to exclude patients that would give false positive BDG results. They were smart enough to do it. Does it make sense what I mean? They had all these exclusion.
Patients don't give false positive results.
They do because most of them, they would be, for example, they think that they would be on steroids. They would be, yes, and they would give. The BDG result would be false positive.
Are epidemiologically higher risk for invasive candida. And that is the reason they got excluded.
Yes, but they are also high risk at giving false positive BDG results. Their main thing was the BDG, if I can use it or not. They try to make it clear. You can discuss it with them. I'm not fighting for them. I just presented the results. You can just discuss it with them, email them.
Agree with what you're saying. I agree with that discussion.
It's very smart actually to me what they tried to do, but they ended up with not a lot of number of patients, but they were smart enough to do it. They are right. They tried to make it as specific as a method as they could.
Did it say somewhere like did it say somewhere you need to send 2 BDG consecutively for it to be a viable?
It's almost a pointless study though,
Because why?
It's almost a pointless study because if for it to be useful, it cuts out almost all of your patients in ICU.
No, you don't have no, you have septic patients. To me personally, I see a lot of septic patients, more septic patients without being immunocompromised rather than not. I mean, how many patients do you have now today that they are hematological patients? You know what I'm not very sure. I mean, I can't say if it is more or less. They chose this group, like these are the authors. They chose this. And this is what they did. And we have to interpret the data keeping at the back of our mind their inclusion and their exclusion criteria. If we want to apply it, fine. If we don't, and it's not, you know, like our patient population in our ICU, again, it's fine. That's how I see it, at least.
For the patients that come to annexes, abdominal surgery, should we do subconscious like for that?
Well, they are inherently at high risk of candida infection.
But you do.
When you start the antifungal anyway.
Our practice is different anyway, because like you said, we start anyway, the antifungals, and then we wait for 1 or 2 results to then say they're negative. It's the false positive say we're trying to avoid. It's the complete opposite of what we're doing. So we're looking for a negative to say we can stop. They wanted an accurate positive.
Exactly, because we want the BDG to stop antibiotics. They want the BDG to start. It's a completely different thing. I liked it as a paper, to be honest.
If it had a higher kind of significance in terms of they had higher numbers,
Yeah.
it would be interesting to say, could we change to do
Yeah.
that way?
Exactly. Any question? I mean, we have
debate,
discussed it. What?
It's a good debate. Glenfield have got bored and left. So
Yeah, I was sure about that.
there's the feedback thing, so that you can give your feedback on Matt and Evie.
Yeah, perfect.
They don't know who said what, so you can be as mean or as complimentary as you like.
Okay.
Okay, thanks ever so much, Evie, for doing that. Good work.
Thank you. Thank you.
Good defense of the study. Well done. Standing up to people criticizing it.
The study, not me.
Week, Richard Russell, who's one of the advanced respiratory registrars, is going to be doing some asthma and airway disease from a respiratory point of view as well as an ICU point of view. So hopefully that will be good. I hope everybody has a lovely weekend.
Thank you.